conference. Not yet. Should I start again? Welcome everyone to the virtual Global Spine Conference. I'm Wende Gibbs from Barrow Neurological Institute. And I'm really excited today to introduce the person you know as one of our great panelists, Dr. Michael Galgano, who's an assistant professor of neurosurgery at UNC. I got to hear him give at least part of this amazing talk not too long ago. And so I'm really excited to hear more about this topic, survivorship and prediction in spine oncology. So I won't waste any more time. Mike, do you want to go ahead?
Yeah, absolutely. Thanks for having me, Wende. This is great. This is a great topic. Definitely passionate about it. It's an evolving, spine oncology is a very evolving field, as we all know, and this is an evolving topic, right? So why don't we start it off, and we'll try to make this as interactive as possible. So I think everyone is very familiar with this slide, right? The NOMS. I think every spinal oncology talk that's given on the planet has this slide, right? To talk about neurologic, oncologic, mechanical instability, and systemic disease. But it definitely plays a very relevant role in survivorship prediction, because I can tell you from my own experience that patients who have a better neurological status, these patients are more apt to survive, right? And we'll get into some of the weeds of all of this, right? Oncologic, the histology of tumor definitely matters a lot. Mechanical stability matters to some extent, and systemic disease matters an awful lot, right? And I think that we have to know that at baseline, we're dealing with stage 4 disease. So inherently, these patients have a limited, is an asterisk there, but they have a limited life expectancy relative to patients with stage 1, stage 2, and stage 3 disease. So right away, we're starting off with a stacked deck of cards that we're dealing with when we have to deal with these patients. So Wende, we can make this interactive. So what would you say, in your opinion, from a radiographic perspective, is in common with all three of these cases? Okay, the case on the left, this is a patient that has renal cell carcinoma. The patient in the middle is a gentleman that has prostate cancer, and the patient to the far right actually has small cell lung cancer. All three of them present with significant, rather abrupt neurological decline. They show up to the emergency department and they're a neurologic extremis. So what would you say radiographically is in common to all of these?
So I hope this is what you're getting at. So they all have high-grade cord compression without perhaps.
What about the site of the disease?
Thoracic spine.
Yeah, thoracic spine. And then I guess the thing that I'm getting at, and you didn't see these slides before, so I apologize for putting you on the spot, but it makes these sessions fun, is that it's all dorsal disease, right? So the conversation that as a surgeon and maybe a radiation oncologist that we have with this patient is very different when we're dealing with a case where we have dorsal metastatic disease, which is very easy to access, right? We do a laminectomy and we take the tumor out and we're done. Surgery like this takes someone like me 45, 50 minutes to do. And if I have our resident do the whole thing, maybe it takes an hour, hour and a half. So what? It's a quick surgery, right? This is a very different conversation with a patient that has a limited life expectancy as compared to a patient that has a scan that looks like this. This is a patient, they're 56 years old. This is a real patient of mine that presented with neurologic extremis, severe mechanical back pain, meaning anytime she gets up out of bed or walks, she has severe pain. It gets better with recumbency. She has mid-thoracic sensory level. She can't, really feel below her chest line. She's got lower extremity weakness, a lot of thoracic myelopathy, and she has an unknown primary. So if you're looking at these, Wende, how would you describe this from a neuroradiology perspective?
Okay, so I hope I don't get this wrong again, what you're looking for from me. So I would say what level that was. I would say it's a lytic metastasis greater than 50%.
T7.
I'm sorry? T7. Okay. So semi-rigid thoracic spine, osseous metastasis extending from the bone into the epidural space, greater than 50% of the vertebral body, at least one pedicle. I'm giving you both SINs, and I'm going to give, SINs, and I'm going to give you the epidural spinal cord compression.
You mean that? Right.
Yeah, except you don't have an axial, unless that's an axial T2, which is what you're supposed to use. But if it is, then it's still a grade 3. We already know that. So probably that SIN score is probably not high. Not high enough to be I don't know, maybe with the pain it is, but it's going to be on the low end of.
I haven't showed Wendy these slides either, just so
Yeah,
you know.
so forgive me for kind of fumbling along here,
No, you're doing
trying
great.
to read your mind.
Yeah. So I guess my point here is that this is a very different conversation that we have with the patient and their family, their loved ones, right? If you have a dorsal, metastatic deposit, that's easy to access. Even if they have a limited life expectancy, we could take them to surgery. It's not a big operation, not very bloody. We're in and out in 60 to 90 minutes, right? This is a much different animal, right? Let's look at their SIN score. This is a semi-rigid region of their spine. They do have a lot of mechanical back pain. It's lytic. There's no deformity. There's no collapse, but there's greater than 50% of the vertebral body involved. And as Wendy had alluded to, there's a unilateral posterolateral involvement, unilateral pedicles involved, right? So now we're dealing with the patient. They have a potentially unstable spine. So they have a SIN score of 8. They have a high-grade metastatic deposit. It's essentially wrapped around the majority of their spinal cord. They have an unknown primary, and we don't know a lick about their systemic disease. So this is a big problem, right? These are the types of patients that we see a lot. I see a lot of these patients through the emergency department. A lot more present like this than the patients that present to your clinic, maybe with a little touch of thoracic myelopathy, right? What if you're dealt with a patient like this that comes into the hospital, and not only do they have neurologic extremis, meaning they can't move their legs very well, thoracic myelopathy, but they also have a sagittal plane deformity, right? Can you reconcile taking a patient like this to surgery for a big operation like this short video clip shows, or a patient that presents with a pathologic fracture like this, and now they have severe compression of their conus medullaris, and they're having bowel and bladder problems and lower extremity weakness? Does the thought process change? What if you're dealing with the child? These next 2 cases I'll show you briefly, these were children I took care of. This was a 15-year-old girl that has metastatic rhabdomyosarcoma, right? Does that conversation change about survivorship when you're dealing with the child? This is a kid that has epithelioid sarcoma, metastatic disease. This is not primary. This is metastatic to the sacrum, L5 and L4. L5S1 roots are completely wrapped up. Does that conversation change when you're dealing with a child, right? So why do we care so much about accurate survivorship prediction? I think the main reason that as radiologists, spine surgeons, ortho, neuro, radoncs, medoncs, what we ultimately want to do at the end of the day is to be able to stratify the treatment options from aggressive to palliation, right? If we know that a patient, predictively has 3 months left to live, we're going to offer palliation as opposed to one of these really large scale, big aggressive surgeries. And ultimately what we want is to provide meaningful recovery for our patients, right? We want them to reap the benefits of our intervention. And what we don't want, and unfortunately many of us who do spinal oncology surgery have seen, is that patients end up spending the rest of their life oftentimes recovering from operations, right? And I think we have to reconcile with the fact that there's about a 10% mortality within a month of spinal oncology surgeries. There's about a 40% complication rate as well, right? Not all surgeries are big and gruesome like this. This is a fairly, big operation that we did for a metastatic deposit about a year or 2 ago when I had been in New York. But there's a lot of complications that goes along with these surgeries. You could have a lot of wound problems. This is by far the most common issue that I have. Maybe not a hole quite this big in every patient, but if a patient gets radiosurgery or stereotactic radiotherapy after the operation, they can certainly be at a little bit of a heightened risk of having some wound breakdown. That's not uncommon. It's not it's not super common to see hardware protruding out, but this is an extreme example. You could definitely see a lot of skin problems, right? You get subfascial wound dehiscence. You could get infected wounds. This is a big problem, and oftentimes we have to have our plastic surgery colleagues get involved to help us out with these. You could have cement extravasation into the canal. You could have hardware failure. Again, these are some extreme examples of complications. And those of us that do a lot of deformity surgery, I know Alex is on the call and Mike is on the call. We see these problems a lot in the deformity population, but we're starting to see them now in the oncology population, because what's happening is that these patients are starting to live longer, right? The pathomechanics for PJK in the metastatic disease population is a little bit different, right? These patients can get adjacent segment oncologic disease. This was a patient I took care of a few years ago when I had practiced in New York that had an L3 renal cell carcinoma met. So you could see we took her for 2 up, 2 down. we did a partial corpectomy, and just to save some time, get her on and off the table quickly, we did a intraoperative vertebroplasty, and she did great for about 8 or 9 months and presents back hunched over. She's got a lot of mechanical back pain, and if you look closely, I don't have an MRI here, she's got some adjacent segment oncologic disease, and she has PJK, right? So now we have to take out our tricks to help prevent PJK once again. And again, these patients are living longer, right? These patients with renal cell, maybe they're living, 4, 5, 6, 7 years after their initial diagnosis. So now, it's not just about treating the deformity patients with PJK prevention. Now we have to give high consideration to treating the oncologic patients, someone like this, with PJK prevention as well, and putting some of these sublaminar bands and whatnot. So why else do we care about accurate survivorship prediction? And this is kind of a touchy topic, and I'm very curious to hear what Mike and Alex and Wendy and some of the others and anyone in the audience that would like to participate as well, is that the concept of we live in a very cost-conscious healthcare environment right now, right? So we ultimately aim to appropriately allocate resources to patients that have the longest projected survival. And I know that maybe conceptually this is a bit different depending on regionally where we live in the world. As we know, we've got carbon fiber fixation out right now, and one of the hot topics around that is that tends to be a little bit more expensive than titanium hardware and cobalt chrome and whatnot. No one talks about these. They're a little bit more expensive too, but I use these a lot. Hydroxyapatite screws, right? There's definitely risks with using cement augmented fenestrated screws. I use hydroxyapatite coated screws a lot, but they're more expensive. And how about these big expensive cages, right? So Alex, I'm curious to hear what are your thoughts in your country about aiming to appropriately allocate resources to patients who maybe have a longer projected survival than others?
Yeah, Mike, thanks. So this is an important question, and it's hard to answer because there's a lot of going on in the last few years, couple of years. Like, let's jump back 20 years ago, 15 years ago, when I started with spine surgery. So metastatic disease was always just the discussion: decompression alone, laminectomy alone versus laminectomy and fusion or stabilization. So fusion and stabilization is pretty similar terms, but we know there are differences. So and whenever we have seen these dorsal metastases, there was always the question: how many laminals can you take out? When do you have to stabilize? And now we are talking now, 15 years later, about fancy implants, very expensive implants, and I think there's a big bias. We have so good results with titanium implants and conventional stereotactic radiotherapy, but always we ask if there is a chance to do proton therapy, proton radiation. And when you use titanium, our radio-oncologists refuse to do any proton therapy when there are titanium implants. So there's a trend. We have a company here in Switzerland who's promoting carbon implants. There's a trend to use carbon implants in metastatic disease as well. But when it comes to survivorship, I think in metastatic spine, the implants will not make a big difference. It's the chemotherapy, it's the systemic therapy that counts a lot more than the implants that were chosen by a spine surgeon. So it's interesting. The trend is going to carbon implants, but it's not like a guideline from our society to use them.
Right. And it's interesting in our country, a lot depends on the payer mix, right? I understand in your country, the healthcare environment is drastically different than in the US. But if we're using carbon fiber implants in a patient that's uninsured, the hospital ends up eating up that bill, right? And hospitals don't like that, obviously. Obviously, if a patient has private insurance, they're reimbursed very well if we use something like one of these expensive, titanium cages or carbon fiber implants. But I do think it's a relevant conversation to have, in regards to survivorship prediction, right? Are we going to be using in the uninsured patient very expensive hardware in a patient that maybe has a projected life expectancy of only 8 to 12 months, as opposed to using titanium implants and cement as opposed to carbon fiber in one of these expensive cages. Wende, do you have any feedback from the interventional radiology perspective, or is this not as relevant in your world? I think Wende may have stepped away for a second.
Hey,
okay.
sorry, I'm running back. I apologize.
That's okay. That's okay. I'm sorry.
Get the door. I apologize. So you said, do things like carbon fiber have an impact on us? So obviously radiologists don't have anything to do with what you choose to use at all. But I would say in terms of getting quality interpretation of images, if you want to know if there's residual or recurrent tumor or anything like that, having something like this, I think, is vital. So again, I mean, I don't know, that doesn't answer the question whether who gets, the expensive or whatever screws, but it definitely makes a difference. I have no control over it, but I would say it's important from our perspective.
Yeah, I think at the end of the day, as a surgeon, we just have to do what's right by the patient. I personally, I don't care what type of insurance or lack thereof a patient has. If they come in through the ED and they have oligometastatic deposit with severe epidural spinal cord disease, and I feel that they may be a good candidate for separation surgery and SBRT afterwards, I don't care what type of insurance they have. Carbon fibers approved at UNC, that patient is probably going to end up getting carbon fiber. Not a lot of patients present with oligometastatic disease, so most of my patients in this population are not treated as such. But if that patient does present, I think you have to do right by the patient, right? I personally have migrated away from using a lot of these larger, expensive titanium expandable cages in this population. Again, not because of the cost, it's really just because I could get these patients on and off the table a lot quicker. If it's in the lumbar spine, I don't have to sneak these cages in through the lumbar nerve roots. I can inject, 10 or 15 cc's of cement and get in and out a lot quicker, and I'd have to take a bunch of fluoro. So again, I don't want to belabor this point, but I think it's a relevant topic that you bring, that we do have to talk about with survivorship prediction in patients. I think before we talk about how we do predict survival and mortality in this patient population, we do have to talk about some of the prerequisites that we look at, right? So I think the most important by far is cancer type. We have to know what the histology is, because this plays a very big role in prediction of survivorship. We have to understand sensitivity to specific interventions, and this is tied very intimately to what their oncologic disease is. Which treatments have been exhausted? This is very relevant to patients that have breast cancer, right? Systemic disease burden. What is it? We have to look at their medical comorbidities. So not all of these patients, are the healthiest at baseline. It's not just about whether or not they have, liver mets or lung mets. It's, do they have COPD? Do they have coronary artery disease? So we have to look at this as well when these patients come in to either our clinic or the emergency department. And it's difficult to quantify this sometimes, but what's their level of nutrition like? Are they going to be able to heal up their wound? Are they on chemotherapeutic agents that do not allow them to mount an immune response and be able to fight the woes of infectious disease after they have radiation or even after just a big surgery alone? Something that I look very closely at in all these patients is their Karnofsky performance scale. I look at their functional status. One of the first questions I ask the patient is, before you present to the ER, what were you doing a month ago? What was your functional status like? Had you been bedridden for 6 months, or were you very functional and still going to work every day up until a week ago until your legs stopped working, essentially, right? For me, that's a very important piece of information. And then obviously looking at their mechanical back pain status, which is a surrogate for spinal stability, neurologic status, right? If you do a PubMed search and you look at metastatic spine tumor survivorship prediction, you're going to find a plethora of results. You're going to find close to 150 results. And I'm sure some of you are familiar with these scales. We have the Takayasu scale, the Tomita scale, the modified Bowers scale. There's a lot of scales that are out there that we could use. There's an enormous amount of literature on prognostication for spine metastatic disease. The big question is, at what point do these scales themselves, have a mortality tag associated with them, right? Because what happens over time is that scale that was once relevant 5, 10, 15 years ago is no longer relevant. in 2023. And there's actually some spine literature to support that. This is an article from JNS by Americ Amelot a couple of years or so ago, back in 2021, that specifically made the point that a lot of these scales that we use are outdated and that they in fact underestimate life expectancy. And if you look very closely at these, the Tomita scale, for instance, that particular study only has 67 patients. The Takayasu had 128, and so on. A lot of these studies had heterogeneity of tumors. Each subgroup was really not all that well represented. The scores were generated from a retrospective database. And then, some of the studies really only looked at a surgical case series, and others only looked at non-surgical case series. And this is really the scale that I use today. I understand that it's not an all-inclusive, all-encompassing scale that looks at every single factor and parameter that's present, but it's a quick and dirty scale that we can use that gives us a very very brisk estimate as to what the expected life expectancy is for patients. This is some work from one of our old partners on virtual spine, my good friend John Shin, looking at the New England Spine Metastatic scale. And essentially what this is a scale that looks at 6 month, 1 year, and overall mortality. The lower the score that you have, the higher your 1 year mortality, and the higher your score, the lower your lower your 1 year mortality is. There's a few things to take away from this. And what this scale particularly looks at is the primary tumor behavior. So it definitely looks at the histology, right? We want to know what type of cancer this is. We want to know what your systemic disease burden is. Do you just have skeletal deposits, or do you have visceral deposits? Looking at ambulatory status. And the authors in this particular study felt that this was a surrogate for pre-treatment function. And then they specifically looked at the albumin levels as well, which was also a proxy for just overall general health and ability to tolerate oncologic treatments. And, I think one of the strong points about this study is that this was prospectively validated at 3 separate academic centers. And if there's 3 things that you could take away from this as far as predictive survivorship at 1 year, it's higher performance status, better neurologic status, and absence of visceral mets. So these are really, the 3 things that I ask patients, right? When they come into the ED, I have my residents take a look, do you have liver mets? Do you have lung mets? What were you doing a week or a month ago? What was your Karnofsky performance scale like? And what is your neurologic function? Because I can tell you from experience that if a patient comes into the emergency department and they're paraplegic, even if it's just been for 24 hours, there's a very high probability that they will end up staying paraplegic. And, from my observation, these patients end up not doing so well, right? Because they could develop DVTs, they get PEs, they get UTIs, they get bed ulcers, they can't make it to their appointments as easily. So neurologic status, in my opinion, definitely has a very, very big influence on how these patients do long term. So I'm curious, Alex, how do you go about predicting survivorship in these patients? Or is this just kind of a back and forth that you have with medical oncology when these patients show up to your clinic or the ED?
Yeah, so this is a very good questions and so hard to answer, because in your practice you're sometimes you have to do these decisions in the middle of the night, and you can't wait until the next morning. You can't ask a round of experienced oncologists. So when a patient comes with a progressive paraparesis, I go into the OR even at midnight or 2 o'clock if it's emergency. So I go back to the questions you mentioned before. What is the performance status before, not the day before, but the week before? And I completely understand the need to find objective predictive factors. But on the other hand, we are all biased by our experience. And if you go to the ER, if you go to the ED and you see the patient in a bad condition, like small cell lung cancer, sometimes you have the feeling, oh, he won't make it many months. He will probably die soon. But then the oncologists say, yes, it's a small lung cell cancer, but these small lung cell cancers do respond very well on the first chemotherapy, and they can make a really rapid rapidly better, and the performance status can really increase fast within several weeks of chemotherapy. And so your personal experience, your personal view on the patient can lead you to the wrong decision. This is so hard. We have tennis players with prostate cancer going paraplegic, and we know exactly they are good, they're high performance, and we can help them. And it is so hard to look all these scores in an emergency setting. It's so hard, and if you're young, you think you have to help them. If you're older and you have seen so many patients you didn't help, and you ruined the rest of the life being in hospital, staying in hospital for weeks after surgery, it's so hard. And I completely understand the need for scores, but I can't give you the answer what is the best. So I always do. I still do bad decisions in oncologic cancers. I have to admit, some people I operate in a year and they die within 3 or 4 weeks, and always say, "Oh, shame on you, Alex! How can you miss the this situation?" And I'm really more aggressive than others, perhaps, because I don't want to say no to a surgery for a patient who could recover from a paraparesis with a surgery. It's really difficult to answer. I can't say it better.
Yeah, I completely agree. This is, this is probably one of the hardest things that I have to grapple with, a few times a week, right? A lot of these patients, unfortunately, are really not great candidates. And, we probably see a few of these a week at a big academic center that come into the ED that have, some type of back pain. They have metastatic deposits everywhere, but so many of them are just not good surgical candidates. But then every once in a while, you get someone, as you said, Alex, so nicely, that comes in with a neurologic deficit, and it pulls at your heartstrings, right? Because you want to be able to help them, but at the same rate, you also don't want them recovering for the rest of their life from your intervention. So it's a difficult topic for sure. But I do think that having something that we could kind of slap on the wall of our resident room or maybe our office to give us kind of a quick and dirty, prediction as to what their survivorship might be. I do think it's helpful. It's definitely helpful for some of our trainees. So
Yes,
this has kind of been my go-to skill.
Sorry, this is something we learned in the Corona pandemic. There was a patient on the intensive care unit suffering from Corona, recovering, and then going paraplegic to a metastatic spine disease. I remember him very well. So what is the best decision with the patient shortly after COVID-19 infection going paraplegic? What is your score worth in these situations? It's so hard, and you need experience, but you need also objective predictive factors. And we have these scores, we use them all. The best is the SIN score, I guess, and these Kanofsky, and I like this New England score as well. I didn't implement it yet, it's too new, but I think after the session I will do so.
Yeah, and we're going to get into some of the weeds of some of the other scales that we could use too. And it's definitely well beyond what their mechanical stability is like, neurologic status, systemic diseases. There's a lot of other factors that are starting to surface now that we'll get into. So it's not always about all of those factors, right? I think we have to acknowledge that a lot of these patients do in fact have changes in life expectancy. This is a slide that a lot of senior spinal oncology surgeons that I've looked up to over the years, and I've essentially memorized some of their lectures. This is a slide that would always show up, right? Lung cancer, you have 4 months left to live. Breast cancer, 24 months. Prostate cancer, right? This would show up in every one of their lectures. But this is false now. This no longer holds true, because now we have checkpoint inhibitors, we have personalized therapies, we have immunomodulators, and it's really changing the landscape. So, there's kind of an emerging field now, and I'd love to hear Wendy's take on this as well. And John Shin has put forth a lot of effort in publishing some great papers on this. We're now starting to evaluate we're trying to quantify cachexia, right? That's really what we're looking at, evaluating frailty, mortality, complications associated with metastatic disease. Sarcopenia is something that a lot of surgeons have started to look at. So what is sarcopenia? Sarcopenia is a loss of muscle function, and it's a loss of muscle mass. And we know from our literature that that this accurately predicts overall health and the ability to essentially survive a malignancy. And there's been some great work at Henry Ford, one of our neurosurgery colleagues, Victor Chang and colleagues, had published these papers in operative neurosurgery, neurosurgery, the Red Journal a few years or so ago. And what they found is that the psoas muscle is a very good surrogate for sarcopenia. And they found that irrespective of what the tumor histology is, having a lower overall surface area of your psoas muscle, in fact, is associated with lower survival. They've also shown that this predicts a 90-day overall mortality, again, independent of demographics, functional, oncologic, and surgical characteristics. So, Wende, I'm curious, is this something that you use in your practice at all as a neuroradiologist? Do you ever document the quantification of sarcopenia, or are we not really there yet?
No, that's something I hadn't even heard of until maybe, I don't know, a year and a half ago. And actually, you were showing some of the great papers, and I want to give a shout out to Chris Ames and Mike Sappy too, they've done a lot of good work from the West Coast on this stuff. And I really learned from Chris about this. So this is not something we ever learn about in radiology. And, measuring muscles, I think somebody a week ago in the spine conference we were in asked me if I ever do that. And it's like, I didn't even know that was a thing. So from our side, that is not something we do. Now, there is a lot in the literature about automated segmentation algorithms now from the body radiology side that is going into predictive analytics for a number of different cancers, but it's not in the spine surgery world, except the one link I think that you showed a second ago was Ali Bassad's paper with John Shin. So I think there's so much in different silos that's going on that we're all kind of accidentally finding out what everybody else is doing. But to answer your question, this is not something I think any other radiologist knows about, at least in neuro.
Yeah, the reason I like this, I'm a surgeon. I like things that are simple, right? Our job on a daily basis is hard enough. And I think sometimes we take for granted the complexity of surgeries that we do. So we want a scale. We want, we want literature to support simplicity for helping us to predict survivorship, right? So Alex, I think this is probably something that you could help your patients with. You could take away from my talk tonight is how we quantify sarcopenia. And I didn't know this before I gave a talk a few weeks ago on Seattle Science Foundation, the Spine Tumor Symposium with some fantastic spine oncologists, is about quantifying sarcopenia, right? So how do we go about doing this? We could look at the psoas volume, and we specifically look at either the L3-4 disc or we look at the L4 pedicle, right? The psoas is a very easy muscle group to be able to measure a surface area for. It's not like the multifidus or some of the other paraspinal musculatures, which are very challenging to isolate radiographically. Would you agree with me, Wende, that this is probably the main reason why the psoas muscle was chosen to be utilized as a surrogate for sarcopenia, or am I a bit off?
Maybe. I'm just shocked that has correlated with anything, because it's so different in everyone, and you don't see anyone that looks like your first picture out there, except for the occasional young football player who came in with a disc.
Right. But this study at Henry Ford, really showed quite nicely how it is significantly correlated with survivorship at 1 year. So, Alex, this is a great way that you can again get a quick and dirty measuring of what survivorship at 1 year is. Again, it doesn't encompass every single factor, but this is easy, right? You go into your PACS system, you right click, you hit ROI elliptical, and or free, and you literally will kind of draw freely a line with your mouse around the psoas at either the L3-4 disc level or the L4 pedicle level. And it generates, a plethora of all these numbers, and some of them are very relevant. One of them that we use to have as a surrogate for osteopenia, osteoporosis, is the Hounsfield units, and my good friend Ben Elder has a fantastic body of literature supporting this. And something we could look at too is the psoas volume. So if you look closely here, this particular drawing, you can see that the surface area is 7.4 centimeters. And if you look closely at this particular study, it breaks it down into males and females, right? And further breaks it down into different tertiles. Patients who had lower surface area of the psoas surface area of the psoas volume at the L4 pedicle, they had lower predictive survivorship at 1 year as compared to patients who had a thicker surface area at the L4 pedicle area. So you may be wondering, what about patients that have short stature, right? So this particular literature alludes to the fact that both psoas volume and vertebral body area are in fact based on stature, but psoas volume is likely to decrease with sarcopenia, and vertebral body area should not. And what this generates is a ratio, right? We now have a ratio of average psoas to vertebral body volume. Taking this a step further, not just looking at sarcopenia, not just looking at psoas volume, John Shin and colleagues have looked at overall body composition. And what they found is that at 1 year, patients that have a lower degree of skeletal muscle mass, lower skeletal muscle radiodensity, which equates to lower muscle quality, have decreased visceral and subcutaneous adiposity. These patients are at a much higher risk of decreased survival at 1 year. So again, they're taking this to the next level, looking at a lot of other factors, not just looking at sarcopenia, but looking at overall body composition as well. And essentially what we're doing here is we're quantifying cachexia. I think a lot of us, we use what's called the eyeball test, right? We walk into a patient's room, and oftentimes I'll ask my resident, if I haven't seen the patient yet, do they pass the eyeball test? And what they're doing is they're using their experience and they're giving their gestalt for how a patient looks. What John Shin and colleagues have done, they've quantified that for us, right? So Wendy, I'm curious, do you have any feedback about this? I know you're very well versed in this topic, and I've heard you
Yeah,
give.
I was so excited to see this paper come out because I thought first I thought I was the only one thinking about this, and I saw Ellie's paper and John's paper, and I was like, oh man, they're way ahead of me. And this is great paper. I encourage everybody to read it. It's new, and so there are a couple things in the area of segmentation that maybe a radiologist would need to figure out in terms of technique. But it's, I think this is probably the future, looking at all these different measures and maybe more than these or different ones, because there's a lot of different things you can look at on a CT. So that's just a brief overview. I don't want to.
Is there anything from a neuroradiology perspective that you feel would be relevant that has not been incorporated yet into our current body of literature for predictive analytics?
Well, I mean, when you're talking in the beginning, I think one of the first things you might have said was something about cardiac health when you're talking about you think about that for your patients. Is that right? Did you say that?
Well,
did I hear you?
Well, that paper that I showed, that beautiful drawing of sarcopenia and the gentleman on the treadmill, that was actually from a cardiac health journal, believe it or not. That's where that artistic illustration came from. So there's definitely a lot of literature supporting cardiac health with sarcopenia as well.
Okay, it's things like that. I mean, this doesn't have anything to do with the heart, with these factors right here. The heart, the aorta, they're all, coronary arteries there in those pictures too. So things like that. What are the most important things that you think of, and what kind of imaging correlates can we find it? Could be biomarkers for those. That'd be my answer to that.
Right. I think I also have
Mike, it's Mike Selby here. How are you, mate?
Mike, what's up? Go ahead.
Hey, I just wanted to ask Wendy and maybe AT's there as well, Alexander. Something I've noticed a lot, and I love the psoas measurement. I reckon that's a really cool idea. The only thing is you've got to be really cautious in patients that have had a hip replacement, because patients that have had a hip replacement, their psoas can atrophy. And there's a couple of nice studies out there that show that.
I think, Mike, that's a great point. I was thinking the same thing as he was saying it, or even anybody who's had prior surgery or anything, right? You'll get some changes, right?
Yeah, that's a great point. And I think they started to allude to something along those lines conceptually, that you just can't look at the psoas surface area volume in isolation. And what they were getting at is that just based on a patient's specific stature, they may have a lower volume because maybe they're just a more petite individual, right? Mike, that's a great point. I actually didn't know that. I had no idea that the psoas volume will decrease if someone has a hip replacement. But again, this is just another factor that we can further, fine tune these, predictive tools with. I do have to give good credit to a good friend of mine at Duke University, Rory Goodwin, Ori Barzilay from MSK. He's works obviously with Mark Bilski. They've done some fantastic work with molecular markers and targeted therapeutics. They're now looking at targeted therapeutic data and using this specifically for prognostication. Chris Ames, Ron Lehman, Nathan Lee, they've looked closely at artificial intelligence and machine learning applications in spine surgery. And now this is being brought over to the spine oncology forum as well. Again, our colleagues at MSK, they've looked at a machine learning prognostic tool. It's called OncoCast. And what this specifically does is it looks at the clinical characteristics of the patient, pathologic features, and molecular profiling. So I'd be remiss if I did not speak about experience, right? And we've talked about all these scales, sarcopenia, body composition. We've looked at the disease, the metastatic disease profile, systemic disease profile, where they have their deposits. Is it liver? Is it skeletal mets? How all of these factor into the equation for predicting what a patient's survivorship is. I think there's definitely something to be said for overall institutional experience, especially at big cancer centers like Moffitt, MSK, MD Anderson as well. And then there's something to be said for individual experience. And I think Alex has kind of alluded to this a little bit. So this is a patient of mine, probably one of the first metastatic disease patients I took care of after I had just finished my training with Ziego Koslin at Brown. This was, about 5 years or so ago. It's a patient that has a history of renal cell carcinoma, and they have a metastatic deposit at the level of L2, and they essentially presented to us with Claudia equina syndrome. She was having trouble with bladder retention, bowel movements, a lot of difficulty walking, a ton of back pain. And I'm in my first year in practice, actually in my first few months in practice, and I can be completely honest with all of you. I had no idea about any of these predictive scales, right? Tomita, Takayasu, there were so many of them. There wasn't any one particular one I was using. All I knew is that the surgery that this patient needed, I knew how to do because I trained with Zia, right? And you can probably imagine about a year and a half later, this particular case wound up on my neurosurgical board exam, right? And there's a reason for that. So this patient also had a left frontal mass. They also had a history of renal failure. They also had a history of a kidney transplant and were on, immunosuppressants. They were on chronic steroids. But the patient was only 54 years old, right? So she pulled at my heartstrings, and I felt that I could treat her. So I'm curious, Alex, in this situation, or Mike Selby, what would you do in this situation? You have a patient that has a lot of medical comorbidities. They have a pretty high systemic disease profile. She was fairly, or reasonably functional before all of this happened, to the point where she was still living independently, lived by herself. But as you could see, her entire spinal column is completely peppered with metastatic deposits. So how would you deal with a patient like this who has an acute neurological deficit? And I'm curious to hear your all feedback. Would you offer a big surgery? Are you doing one up, one down with cement? Are you doing a lateral? What would you do for a case like this? And then I'll share with you what I did and ultimately what got me in trouble.
Yeah, so it's for me it is the less invasive. So I would do perk screws to up to down with a little bit of cement cautiously, because cement leakage is a bigger problem in a metastatic spine than in osteoporotic spine. And then I would do a limited medial incision and do a laminectomy of L2. So it's a combination of laminectomy plus percutaneous stabilization. This is what I do in my hands quite very often.
Mike, any thoughts? What you would do in this situation?
Very similar to Alex, actually. I've got similar cases where I've done the same thing, and I think going after the lesion with a corpectomy is something I'd reserve for someone with a lesser disease burden in the first instance. But I think getting a little bit of space at the back of the canal there, and then perk screws up and down with a bit of cement is a very good idea. I may even be tempted in this case to go 3 up, 3 down with perk and a mini open lammy, but that's up for debate. But yeah, very similar to Alex.
Right. So I'll show you what I did. This was a case I did 5 years ago. Some of you have seen a video similar to this or this exact video. I took her for what both of you advocated to not do. I took her for a corpectomy. I knew I could do the surgery. I could sneak a cage in through the nerve roots, 6 or 7 hour surgery, 7 hour anesthetic event, almost a liter of blood loss, boatload of postoperative pain, right? X-rays look okay after surgery. Can you guys guess what happened to this 54-year-old lady? Well, she came back 8 weeks later. She was septic, had an opened wound, was draining pus everywhere, and she died. She died 2 months later, right? So I think that there's definitely something to be said for, fortunately or unfortunately, having a cohort of patients like this in our experience, right? That we can say, that we can reference 4, 5, 6 years later and say, you know what? I've taken care of a patient that looks just like you, and putting you through an operation of this magnitude is not in your best interest. And then I think you can also, ask the question, should we even operate at all in this situation? She had a left frontal brain met. She had visceral metastatic disease to her liver, to her lungs. If I had instituted one of these predictive analytic scores, like the New England Spine Metastatic Scale, probably would have told me that she had 6 months left to live, right? Instead, we offered her a really, really big operation, and she ended up recovering from surgery for the remainder of her life, right? So I think over time, we have to evolve as spine surgeons in our technique and our thought processes. And I think this is where, separation surgery comes into play. So rather than taking patients for a large scale corpectomy and taking out the epidural disease plus the vertebral body, we can now just take out the epidural disease. Maybe we can use, as Alex had alluded to, carbon fiber fixation so our radiation oncologists can better see the spinal canal and take them for separation type surgery. So this is how we do separation surgery. This is a lot different than the last surgery that I showed you. This type of surgery takes me maybe 3.5 hours as opposed to 6 or 7 hours. We still have to take the facets down, still have to take a unilateral or sometimes bipedicular approach, but rather than digging into that vertebral body, taking the disc above, the disc below down, we can cut the nerve root. We could sacrifice it if it's anywhere in the mid-thoracic region, such as this case. We could take out just the ventral epidural disease, cut that posterior longitudinal ligament, which is a hallmark feature of separation surgery, bring our ultrasound in, make sure that we've got good circumferential decompression, drop our screws, drop our rods, and we could get a very reasonable radiographic and I think an excellent clinical outcome in a lot of these cases. This is what the postoperative MRI scan looks like. You can see the vertebral body is still completely intact, but the epidural disease is gone. Scaling down the operation even more. What if you have a patient that has a single metastatic deposit, such as this case, and this particular patient has severe thoracic myelopathy? Maybe they have a limited life expectancy of a year and a half or so. I used to take these patients and I would do 2 or 3 up, 2 or 3 down, corpectomy cage, cut the nerve root. Instead now, we could do a unilateral approach. We could place 1 screw up, 1 screw down. Dealer's choice if you want to use cement augmented screws. I've actually moved my practice to using a lot of hydroxyapatite screws. And, we don't talk about this a lot. I'm curious, Mike, Alex, do you all ever use hydroxyapatite coated screws in a case like this, or you still using cement augmented screws?
Honestly, never. I've never used hydroxyapatite. Never.
Mike, I use them a lot in different settings, but it's not a bad idea for this particular setting. A lot of the pediatric tethering screws come with a bit of HA coating for various reasons, anterior vertebral body screws. And so, it's not a bad idea, actually. I mean, cement certainly has its downsides. Look, carbon fiber is the other option. I'd had a really good experience with carbon fiber until a case the other week. I suppose just a word of warning to those of us that want to use carbon fiber in younger, better bone, that it doesn't work that well.
Right.
I don't know what your experience is with it, but I used carbon fiber in a situation where a young man had a pseudarthrosis around a fusion for spinal cord injury, and we really wanted to see his cord better than what we could with his implants in. And it was really a minor revision for stability, and I got some anterior into body support. So I thought I'd use carbon fiber. So when we were putting the carbon fiber in the back, because he'd had previous screws that had been taken out, despite the fact that we tapped and did everything as per the manufacturer's instructions, the screw heads were shearing off during the last part of insertion. which I suppose indicates to me that these are not for high demand or good quality bone situations. And it kind of indicates my previous attitude with them, where I just use them at the tumor level and I'd use titanium above and below. I'm just not convinced these carbon fiber screws are going to last long term, actually, the ease of which those heads were shearing off during this case.
Yeah, I've had actually a similar experience. And, typically I'll preface this by saying that the main indication is for metastatic disease, right? You're typically dealing with pretty cruddy bone stock. But I've used it in a primary bone tumor. I did an aneurysmal bone cyst in a 23-year-old male a few years or so ago in New York. And as we were inserting the screws, despite the fact that we followed all of the manufacturer's guidelines and whatnot, I actually could not get the screw in. And so we actually had a helicopter to screw into the vertebral body, believe it or not, which was a bit of a disaster, right? This should be the easy part of the case. So I think carbon fiber fixation is fantastic. There's definitely a place for it, but to Mike Selby's point, there's definitely a word of caution for patients that do have very good bone stock.
Can I ask a question about, I'm actually fascinated by that. I'd never heard that before, because even though I have no choice in this matter, I have actually been part of this discussion a lot over the last couple of years. And we were talking about how the use case for pediatric patients, that is like the best use case for these, because they're most justifiable, because they'll be getting imaged for so long. And so that's surprising to me that doesn't work. I'm wondering, is that something that can be overcome, you think, or is that going to be a problem with them?
I think we're all learning, to be honest with you. Per the manufacturers, you're supposed to do what's called line-to-line tapping. So if you're putting, 6.5 by 50 screw in, well, you should be tapping to 6.5. And what I've realized, a few months or so ago is that sometimes you actually have to over tap in patients that have very good bone. And otherwise, what will happen is that your screw will end up being very proud. Your tulip head is proud relative to the other screws. And then it could be a little bit of a challenge getting your rod in. So these are kinds of things that we take for granted when we use titanium, cobalt, chrome, and whatnot. But with carbon fiber screws, there's definitely some nuance to how you place the screws. And I think as we all have these discussions, as time goes on, I think we're going to learn from each other's failures and whatnot for what works and what doesn't work.
Interesting.
So scaling things down even further, right? We talk about separation surgery being an operation where we still have to take the pedicles down, still take the facet joints down. What about a case like this? This was a medical professional I took care of not that long ago in North Carolina, actually. She's a young lady. She's got a young family at home. She unfortunately has metastatic non-small cell cancer and presented to us with a thoracic sensory level, kind of at the nipple line. And she's having a lot of thoracic myelopathy, and her symptoms came on relatively abruptly. So what are you thinking, Wendy, when you see a patient like this that has a scan that looks like this? They're doing completely fine. They're working as a medical professional. Then all of a sudden they start developing this abrupt onset sensory level and, subjective weakness in their legs and thoracic myelopathy.
So for me, anytime anybody has acute onset of symptoms, that to me says either ischemia or bleeding, whether it's in the brain or whether it's in the spine or anywhere. That's number one. That or fracture, like if either of those things I would think would cause acute symptoms.
Right. And that's exactly what happened here. You're completely right, Wendy. So she actually bled. This young lady, she actually had a hemorrhagic metastatic deposit for non-small cell. And, my point here is that it's okay to still take patients for a laminectomy once in a while. So this tumor, as you could see in the bottom picture, the axial cut, this tumor still wraps around the spinal cord, right? But if you look closely, she's got deposits in 4 levels above. And one of my concerns was that she's still a functional medical professional. She still goes to work every single day. She doesn't have great bone stock. She's currently getting chemotherapeutics. And I was concerned about if I start placing screws and rods in her, what's going to happen once I start placing, titanium screws or even carbon fiber into these levels. What happens if she fractures through here? So I had a conversation with her about the pros and cons, and we took her for a laminectomy. And I just want to make the point that I personally think that's still okay to do that. I know there's been a lot of literature showing you shouldn't do laminectomies in patients who have ventral disease. But what this case taught me is that you could still get a very good separation, even with a laminectomy, especially in patients who have, as Wendy alluded to, a hemorrhagic tumor. And that's essentially what she had, right? Patients that have metastatic deposits wrapped around the cord, they don't typically present with an abrupt onset symptomatology. unless they have an acute fracture, unless they have some type of ischemic or vascular event. In her case, this was a kind of a pseudovascular event. She bled into the tumor and she still had tumor wrapped around her cord. We were able to do 1.5 level laminectomy. We could get her 90-degree angle Woodson or dental tool, and we could reach kind of in front of the spinal cord. And this is what her axial looked like. And we were still able to send this patient for stereotactic radiosurgery, not hypofractionated radiotherapy. We actually just sent her for her 3rd session recently for stereotactic radiosurgery. So I do think that there's definitely still a place for doing a laminectomy in patients. You have to have that pro-con conversation with them, that if she did develop a radiation-induced or a pathologic fracture, you're going to end up back in surgery. But again, my point, it's still okay to do a laminectomy on occasion in some of these patients. And I don't think that we should completely take that off the table and be confined to, we need to put 2 or 3 level screws and rods above and below in every single one of these patients. This is a patient, believe it or not, I actually saw today in clinic. So I just threw this into the presentation today. This is a patient who has breast cancer. She presented with back pain. Okay, I got her very urgently into my clinic after I saw the referral a few days ago, thinking she's going to have severe thoracic myelopathy, profound back pain. This patient looks fantastic. She doesn't have clonus. She has no brisk reflexes. She has maybe 3 out of 10 back pain, right? It's okay sometimes to watch these patients. You know, the surgeons on here, and Wende too, may look at this and say, Galgano's crazy for watching this, right? But this is a patient that has metastatic disease. She's very functional. She lives alone. She takes care of herself. She still drives a car. She's a novelist. She publishes research. She used to work for a university in the area, North Carolina. And, you know, she has a very scary looking CAT scan, but I do think it's okay to have that conversation with patients and say, for me to fix this, I have to deal with her osteoporosis, because when you measure her Hounsfield units, they're about 50, right? And then on top of that, you know, we're looking at a pretty big operation here. We're putting, you know, maybe 3 or 4 levels of screws above and below, hydroxyapatite, cement augmented screws. I do think in this case, if you take a patient like this to surgery, you have to talk about anterior column reconstruction. So we'd be taking a very functional human being and confining them to a hospital bed, probably for the next several weeks, recovering from a surgery like this. So again, my point is that it's okay to treat patients conservatively in this patient population. They have a limited life expectancy, but we don't want them to be recovering from surgery for the rest of their life. Alex, do you think I'm crazy for allowing this patient to go on and live and not give her a brace and just say, give us a call as needed? Is that okay to do, or am I crazy for doing that?
Absolutely okay, and I absolutely agree with all your comments you have given, and it's so important to listen to the patient. History gives you so much information to do the right decision or to go for surgery. But this is a patient definitely conservative in my practice. We see them pretty often. Mike, I have a question to you. All these patients with metastatic spine in Switzerland, the breast cancer are treated by OBGYN. The prostate are treated by urology, and there is a huge amount of patients treated by oncology. How's the system in the US? Is everything by oncology, or is OBGYN treating the breast cancer too?
If you're referring to medical management, it's all medical oncology. The only time that changes, and because I'm a neurosurgeon, I do see this on occasion, especially with my partners who do more brain surgery than I do, is that sometimes we will have a neurologist, a neuro-oncologist who gets involved with administering, you know, chemotherapeutics and whatnot to our intracranial metastatic deposit patients or patients that have primary brain cancers and whatnot. But typically a urologist, you know, an ENT surgeon, they would not be the, you know, the administrators, if you will, of chemotherapeutics and systemic disease modification for this patient population. So it's definitely.
This is interesting because I do different talks when I talk to the specialist for breast cancer, because the breast cancer differs so much from like kidney or like all the other tumors, prostate too, and so I have to do different talks to the physicians, to the medical therapy, and it's so important for me that they are so different. The met spine, the metastatic spine, can be A can be B, can be C. It's a variety of histories, of treatment options, of surgical strategies. It's so hard to put everything into one talk, and it's really great what you did, Wendy, what you did, Mike, giving us a great synopsis of how difficult it is to find a solution for the metastatic spine.
Right. No, thank you for those insights, Alex.
Can I add something to what Alex just said, or ask it? Because this is something I was going to ask if we had time, was about education. So you were talking about all the plethora of scales and scores, and how can you keep them straight? How do you, in the neurosurgical and orthopedic surgery communities, how would you disseminate this knowledge about the best score to use or scale, or does everybody just kind of have to judge for themselves out there?
It's a great question. I think, I mean, I don't know if I should be saying this or not. I think social media has really played a huge role now, right? I mean, look at us. This was all, this was all born out of social media. Anytime I have a publication, the best way that I think to share it with the spine community and all of you is, I'll drop it on Twitter and I'll LinkedIn, and I'll, give credit to my co-authors and maybe a medical student or resident that was involved to try to get them a little bit of exposure, if you will, to the spine community and neurosurgery and whatnot. But I think that's our way of going about disseminating this, right? Because I can tell you every day I'm not sitting on, my computer going pubmed.gov and trying to look up something. My mind goes towards what Wendy posts, or Alex or Mike or John Shin says the latest and greatest article in operative neurosurgery. That's what my mind shifts to. So I think that this is a great way through social media to really disseminate a lot of our literature.
And I'm going to play devil's advocate. It's a double-edged sword, because I trust you and your opinion, but not everybody out there trained with Zia, or people who are not on social media. Right. And so it's hard to know still, I think, what's legitimate and what's not. And that's not just confined to surgery, obviously every area of medicine.
Right. And it's very biased, right? There's so many great minds, great surgeons that are out there, great neuroradiologists that are not involved in social media, that have phenomenal work, that maybe they don't have someone that's kind of pushing that engine and broadcasting it out. Maybe they don't have a good marketing department, right? So you're completely correct, Wendy.
May I just say, therapy strategies became so similar. 20 years ago, there were huge differences between the neurosurgeon who was treating metastatic spine and the orthopedic surgeon. And maybe the Germans have been more aggressive than the French or the people from the UK. And now it became so similar. If you go to the conferences, if you go to the US, and if you listen to John Shin, or if you listen to Boriani, it's so similar. The treatment is not so different where you are and where you're coming from. And this is really interesting. This is something I noticed the last 2 decades.
I know we're running out of time. The last point I just want to make is that, we've spoken a lot about how we can scale surgeries down, right? I think there are a few select instances where we do have to scale up surgeries because our operations can actually influence metastatic disease potential, right? The first example would be Pancoast tumors, right? We can perform sagittal osteotomies, we can get en bloc resection, treat something like a primary bone tumor, if you will, and we could potentially prevent metastatic disease. The other is something that I treat a lot at UNC. When I was in New York at SUNY Upstate, I did maybe 1, 2, or 3 of these cases. I've already done several in my first year. Sacrectomies for rectal cancer. I think Alex had mentioned a while ago that you do a fair amount of these in your home country as well, right? And the reason we do these is we want to prevent metastatic disease. If we have rectal cancer that is contiguous with the sacrum, for those of us that are well versed in it, we can perform distal sacrectomies in a lot of these patients. So I think there are certain situations where we need to scale up our operation. Here's another example of a patient that has a metastatic deposit of renal cell carcinoma inside their spinal cord. So this is an intramedullary met. This is a patient that has oligometastatic disease. Systemically, they're doing fantastic. This is a huge, dangerous operation where, we're not just dropping screws and rods and squirting a little cement or dropping a cage. We're actually, splitting the dorsal raphe of the spinal cord, and we're digging around the spinal cord to safely take out an intramedullary spinal cord met. So I think that there are select situations in patients that have a very reasonable systemic disease profile, good predictive analytics for 1-year survivorship that we can take for an operation like this and have a very reasonable outcome. So that's really all I have. I think the way to wrap this up is I think we have to continue multidisciplinary conferences is something that the big academic centers we're definitely doing. And at some point, there's probably going to end up being some type of an app or something that's simplistic where we could punch in the body composition, their molecular markers. We can use AI. We can use a scale such as the New England Spine Metastatic Scale, and then use that in combination with institutional personal experience and eventually get to the state where we have much more accurate survivorship prediction. So that's all I have for you guys.
Wait, can I say one last thing?
Yes,
I know we're over,
yes,
but what you're saying is just what I've been waiting for to hear. So you're going to put all this into your predictive analytics, into your algorithms, and it's going to come out with something. That to me seems scary. And I think to a lot of people it seems scary, but at the same time, it seems like surgeons would embrace that for the reasons you discussed throughout this whole hour, is these are really difficult cases to know what to do. And even though you all are well, you could do this, you can make these decisions with your experience and your knowledge, but it still would sure be a lot easier for some algorithm to tell you, I bet, what's going to happen and what you should do. Is that true? That's my trying to be.
I don't know if it's true. I don't know. It seems like a lot of information being siphoned into a little bottle, if you will. So I'm not sure what that's going to look like one day. And I don't think we'll all have the same access to molecular markers and all of that, especially in some of these smaller hospital systems. But I think at the end of the day, just as we've consolidated, the modified Bower scale, looking at ambulation status, albumin numbers, the way that John Shin and colleagues have done that, I think at some point there's going to be authors that put together a scale that has body composition, histology, molecular markers. We're not there yet, but I think at some point we probably will be in the future.
All right. Thanks so much, Mike. I think we could have probably had more to talk about for at least another hour, so we'll have to all do this again. Everybody, thanks for joining us. I'm not quite sure what next week is, but everybody can come and see.
So next week is, I'm hosting Dr. Armin Kotri. He's a radiologist from Geneva, from Switzerland, and he's talking about AI, and he's a radiologist, and I'm very happy that that I can host this session next week.
Thank you, Alex. All right, perfect. Well, thank you all so much. We'll see you next week.
We'll see you guys next week. Bye.